Good morning and good afternoon, everyone. Thank you for joining today's webinar, Back to Care in Latin America, Cancer Screening in the Public Sector. A couple of reminders to get us kicked off. So first off, simultaneous translations from English to Spanish or English are available. There are some instructions here for you to follow. If you have any challenges, please let us know through the chat box. We would like to note this webinar is being recorded. The distribution of the recording will happen in the next couple of weeks via email to all of the webinar registrants and will also be available via our landing page. And lastly, please use our Q&A feature for any questions that you may have throughout these presentations. We will be answering them later today during our session. To get us started, I would like to direct your attention to today's first polling question. We would like to ask you, what's the most important action with respect to cancer screening in Latin America? And here are a couple of options. Option 1, increase awareness of breast and cervical cancer. Option 2, improve screening and early detection services, capacity and accuracy. And lastly, improve the quality of cancer registries. So please take a moment to select your answer. We'll allow 30 seconds. Great, thank you. We can now show the answer to our polling question. Let's now take a look at the results of our first polling question. Thank you everyone for your feedback. If time allows, we will direct some of the answers of these polling questions results during our Q&A session. But what's interesting here is see 71% of the audience selected improved screening and early detection services. Good. So for today's agenda, I will get us started with the webinar introduction. Then we will cover opening remarks, back to care methodology and results, how to enhance capacity and precision. We will then cover Q&A from the audience, and we'll finalize today's webinar with a few closing remarks. But before we get started, I would like to introduce today's webinar team. I will start with myself. I am Jordana Wagner and am a consulting director for FrontierView. Camila de Panfilis, Chief Data and Patient Experience Officer with Mammotest. Diego Guarin, Executive Director, Regional Market Access Latin America for Merck MSD. And Alec Lee, Healthcare Research Director with FrontierView. So thank you everyone for joining today's webinar. So let's get started with the webinar introduction. Delayed cancer diagnosis and treatment is the next health crisis facing Latin America. To drive awareness, MSD commissioned FrontierView to analyze publicly available data in Latin America around this topic. Because of data scarcity, Brazil, Mexico, and Peru were selected. These countries have good public sector data available. FrontierView quantified the number of missed preventive screenings during the pandemic, as well as the gap between screening levels and targeted screening coverage of eligible population for cervical and breast cancer. Today, following our opening remarks, we will walk you through our findings. I would like to remind everyone during today's presentation, again, if you have any questions, please use our feature. We would love to hear from you guys. I would like to now pass the word to Diego, who will walk us through our opening remarks.
Thank you, Jordana, and thank you everyone for joining today. I'm very happy and excited to be in this panel. This is a topic that is close to my heart. I'm a medical doctor with public health training, and I think the ability that we have to detect early and to prevent cancer is something that we cannot underestimate. But when we look in general to the programs that we have in place for breast cancer, cervical cancer, lung cancer, colorectal, and prostate, we have many heterogeneity between the countries. And talk about the global perspective, and then if we go to the region, also not only between the countries, but inside the countries. So it's different, the reality we see in the private sector from the public sector. Can we have the next one, Jordana? So when I was thinking about the opening remarks and what we wanted to communicate here is basically a call to action, right? We need to make something to change what we are seeing, not only before the COVID pandemic, but also now that we are after the COVID pandemic. And let's go to the next one, Jordana. So the reason, this is my disclaimer, I work with MSD, as Jordana mentioned, and executive director there, but this my opinion, what I'm going to share with you, and is not representing the company or any of the groups I work for. So let's go to the next one, Jordana. So to open here, so the reason we only focus in these three countries, as Jordana mentioned, is because of the data availability, right? We're struggling to be able to have the same level of data across the region. So we look at all the region, and we also look at the 5 tumors I mentioned. And at the end, we ended with the breast cancer, cervical cancer tumors that have better data and programs that might be more established in our countries. In these three countries that Jordana mentioned, Brazil, Mexico, and Peru. And this slide that you see here, this is part of an infographic of a public-private partnership that was launched in 2014, and that started effectively in 2015 by IPMA and FIPharma. FIPharma is the trade association for the pharmaceutical industry in Latin America, in collaboration with the Pan American Health Organization Foundation. So you see the link there, you will have these slides later, but there are some statistics that were shocking. So the number 2 cause of death, cause of cancer and the second leading cause of death in Latin America, these two cancers, breast and cervical. And in the 2, we have screening, and we have also prevention. And each year, and this is something that didn't change since then, 400,000 women are diagnosed with breast cancer and cervical cancer in our region, and 120,000 women die of breast cancer and cervical cancer in our region. Let's go to the next one, Jordana. And we were having this, and we were doing work, increasing awareness, improving the screening, improving treatment, doing prevention, and then we have the COVID, right? So in 2020, we started with the pandemic. Many countries were into lockdown in the early, third quarter, second quarter of the year. And COVID was not only impacting the health services, right, and moving people that do preventive services, including the screening, to tackle the pandemic, but also was making people feel afraid. They didn't want to go to the hospital, or even if they wanted to go to the hospital because of the lockdown, they were not able to go to the hospital. And we miss many women that were scheduled in that year to do their screening. And you see here an article, and you have the reference that was explaining basically the impact that COVID had in health, and in particular in cancer screening, with different variables, different factors. Can you do a click? In the US, that they have real-time data that we don't have, and this we will discuss later. They have real-time data. They saw in April, remember they started more or less in March when the lockdown started in the US. They saw a drop in mammography, almost 90%, pap smears, colonoscopies, CT scans for lung, and PSA for prostate. There was a big drop. And then can you do the next one? And they estimated, and this is data from IQVIA, they estimated how many tests you were missing, how many lives or diagnoses you were missing, and then what was going to be the impact of these missed tests. In the US, they went back to the levels pre-pandemic in 2-3 months. That is the data that they have. right? So the system was able to recover, use of telemedicine, digital health, they were able to track patients, they were able to get patients back to care. Let's do the next one. In Latin America, again, this is a topic in the public health agenda. This is a reference to an event that was made in July, end of July 22 this year, where a panel of people was conveyed by the dialogue, Inter-American dialogue, including people from PAHO, from the World Bank, American Cell Foundation, that is a think tank, and a patient association group. And they were talking about this. They presented different data on the impact, and the data that they presented was also shocking, right? 90% of the mammographies were decreased. There was a decrease of 90% in mammographies. 80% of patients were reporting that they have some disruption in their cancer screening, treatment, diagnosis. And then when we look at Brazil, and can you do the next click, and this data from FrontierView that Alec will present later, we were also seeing, that there was an impact and this data from the mammographies, total data from the mammographies. So there was some impact also, and then you continue, right, having, fluctuations in the screening. And this is for the patients in the public sector. If you do the next, Jordana, and the private sector, you see the drop in March, April, and then the recovery. So basically, private sector, and this is the point I was making earlier, behaves similarly to developed countries, to the high-income countries. Meanwhile, the public sector behaves not like that, right? And we are still, and you will see with Alec, that we are still, in some countries, not even at the pre-pandemic level. That was not the best, right? It was not the best that we can do in our systems. Go to the next one, Jordana. So I think the people and the community and the governments are realizing of the impact. This is only some screens of news that are coming in main media. So this is not about a journal, a scientific journal. This is basically the main media, the main journals in each of the countries, where countries are realizing of the impact. So from left to right, you have Dominican Republic. Many people is being diagnosed with cancer after 2 years of COVID pandemic. Guess what? People is coming to the clinic, are coming with a more advanced disease. We have countries and payers in countries like Mexico or Argentina or Peru that are increasing diagnosis. They are buying or they are contracting more networks to do mammographies. They are improving the training of the personnel. They are going to do campaigns, maybe with the October month for breast cancer, January for cervical cancer. They are doing different options to be able to really get the people to do the screening. They are passing laws to facilitate the navigation of the patient with the system, and do the next one. And this is across the region, right? It's not only the three countries we mentioned. We have examples from Argentina, Dominican Republic, and Colombia. Basically the same. And as I mentioned, this is only looking at news that came in 22, right? So I'm just looking at some selected news. Go ahead to the next one, please. So with this, and to finalize these opening remarks, what I want to give you is three messages that I think you will see and will resonate with you across the webinar. One, we need to do a better job in increasing awareness for breast and cervical cancer. So we have these 2 months, but we need to continue doing more. Go to the next one. Screening, we need to improve screening. And this is just a graphic of how early can you detect breast cancer, right? And if we are detecting breast cancer with the self-exam the woman can do, it's going to be late, right? So mammography is important, and there are ways to improve not only the capacity of the network that we have, but also the accuracy or the precision of the test that we do. And this is something that Camila will explain later with the example with mammo test and the next one. And the last message here is we also need to improve the quality of the cancer registries. We really don't have the real-time data as the US. We don't have it, right? So when we look, we're looking back. We're looking back 2 years. And when we have the results like this that you are seeing today, these are results that are from April to June, maybe 2022, right? So it's difficult to make decisions if we don't have that data. And when you look at Latin America, only 8% of the people are covered in our region with high quality registries. Technology is giving us an opportunity to improve registries, and we need to take that opportunity and that result of COVID to improve the quality of care that we have in our region. So with this, I will now turn over to Alec, that is going to walk us through the study and the methodology. Go ahead, Alec.
Yeah, no, thanks, Diego. I hadn't was never made aware of that last data point you brought up with the 8% of the patients in Latin America covered by the registries. I think that's a very sort of shocking data point. And I know that there's a lot of countries that are talking about bringing registries, putting them in the forefront of public policy, but we know that takes some time. So it'd be good to see that number coming up. So I wanted to start off, Diego, if you remember going back, I think it was January of 2022, right? So it's been 10 months we started discussing the data problem and this actual issue of the lack of screening during the pandemic. And I remember going back to those conversations, we were, first of all, what's our key question? Well, I think the key question is how many patients didn't get access to screening that would have before? And then second, what does the impact look like? And so we spun our wheels around a lot, as you said, because there was a lack of data. We wanted to do as many countries as possible. We wanted to look at public sector. We wanted to look at social security sector. We wanted to look at the private sector. And we came to the realization that we had to work with the data that was available. So here you're seeing Brazil, Mexico, Peru, but the reason why was because, again, back to your point, Diego, that's where the data was when it came to screening information for breast and cervical cancer. And one more point there I think it's really interesting is, of course, you have maybe some data for screening in Colombia, but what we couldn't differentiate was what part of the data was screening from screening programs and what part of the data might have been tests that were performed on individuals that had already been diagnosed with cancer and that were being followed up with. So that really created a methodological issue. Anyhow, so I think, Jordan, if you move to the next page, and I'll get a little bit more into, Brazil, Mexico, Peru, all those countries have multiple healthcare systems. What are we actually looking at? I'll get into that in a second. But after having that discussion, of course, January 2021, right, is right in the middle of the pandemic. And we were looking at coming off of 2020, that people, especially in Latin America, have not gone back to healthcare systems. They're probably not doing their screenings. So we wanted to look at that impact for 2020 and 2021. But we also stopped ourselves and said, well, hold on a second. Shouldn't we also be kind of analyzing where these systems even started in 2019? In other words, were they at the level, basically reaching their target levels of screening, even as of 2019, prior to the pandemic? So the first question that we wanted to design a methodology to answer was, what is the annual impact if countries miss the targeted screening coverage of their eligible population? In other words, even without the pandemic, if you're at 20, 30, 40, 60% of your targeted population, what does that mean from the perspective of women that end up being diagnosed only in late stage cancer, and then the economic impact for these healthcare systems? The second question, of course, was back to, okay, wherever you started from, you dropped during the pandemic. What is the human impact and economic impact from that impact from the pandemic of those individuals not being able to access the screening program? So Jordan, if you go one more page, I'll highlight a couple of key, let's say, considerations here. I've already mentioned a couple of them, but when we begin brainstorming, how would we do this, right? Because it's not necessarily it's retrospective in the sense that we were able to see in 2020 and 2021 how many women did not show up for screening, but we still didn't know at this point how many women, if those women would ever present, and in what stage they would come back. So we had to make some extrapolations. We have some new data now, and I think it's really cool. Diego already showed some data from Brazil that I'll bring back to the table. But now that we are 11 months further advanced, there's some other studies that would, I think, could be done by people that are also looking at this question to link back with the new data that's available. But what did we need effectively? First of all, detection rates in the existing programs. So those individuals that were passing through these programs for breast and cervical cancer, what was the detection rate within these programs? And of course, this is going to vary. There's different technologies being used, different protocols, different even, let's say, each country was setting a target population with different age ranges. So what were those age ranges? Second, what was the projected average stage of disease when unscreened? The unscreened population presents naturally. And so in other words, for that population, if you think about the population that should have gone through the screening programs but ultimately didn't, either because prior to the pandemic, we weren't at 100% of target, or because of the impact from the pandemic, we want to understand what happens to those individuals that don't get screened. Are they showing up with early symptoms and therefore being identified in stage 1, stage 2, and getting better access to potentially curative treatment, or are they already showing up in late stage disease where the prognosis might be worse? And then I think starting to look at the actual cost, right? So there's really two questions here: is the human impact on one side and the cost impact on the other side. And for cost, what we limited our view on was the average cost of treatment at the different stages for each of the countries that we actually looked at. And I'll get into some of these numbers here in a second. This is really important, right? Because what we left aside, of course, are costs associated with the economic cost of individuals no longer being able to participate in the workforce, which is enormous. The cost for caregivers, for the caregivers of late stage patients, and the emotional cost that falls on the broader family and friends of those patients. On the second question, the inputs were very much largely the same. So the question and methodology is effectively the same. The difference is, instead of looking at the gap between where we are and where we want to be, we were looking at the gap of where we were in 2019. So the success that the countries have had until that point, and the impact from the pandemic, of course. So that means the number of women that all of a sudden weren't showing up. So Jordan, if you go to the next page, I will begin to introduce some of the inputs and the challenges that we had. So I think, first of all, I wanted to highlight that each of these countries, so what are we talking about when we talk about Brazil? Here we're talking about Brazil's public sector, SUS. So we don't have data for the private sector. There is some interesting data, but again, it's data that doesn't necessarily differentiate. They have overall mammographies, but they don't differentiate between what's part of a screening program and what might otherwise being applied for women already diagnosed with breast cancer. So this is Brazil public or Brazil SUS. In Mexico, specifically, we're looking at the SSA. So that would be the public system, also called INSABI. The reason why is that this is the country, this is the segment within this country with the best data. It's monthly data that only has about a 2 to 3 month lag, and it specifies their screening program for both breast and cervical cancer. Unfortunately, the large payer systems such as IMSS-ISTE, that data is not available for. It's either annual or it's not disaggregated to the level that we need it to be. And for Peru, what we're looking at here is the Social Security payer, or S-Salud. So we need to begin to define at that point, what's the target population for each of these payer systems? That required understanding from a protocol perspective, what's the age group that you're looking at? And this is all defined in the report that's available on our landing page. But effectively, it does differ, both from maybe what might be suggested from global health organizations, and also between each of these payer systems. The second thing we need to consider was what do we define the target rate once you are looking at the set of women within each of these pairs, given the targeted age range, and given the amount of times whether the screening program should be done every 2 years or every 3 years. what does good look like? And what that means is no one thinks that we can possibly get to 100%. I mean, I don't want to say don't reach for big goals, but I think that striving for that 100% number actually can create some restrictions even beginning. So what we did is we looked for what does the WHO suggest within that eligible population, given the age range, given the frequency, what should be the target rate? And as we see here, we identified that being at 70%, so it's on the right-hand side, 70% for breast and 80% for cervical. That means that within the eligible population for each of these payer groups, Brazil, SUS, Mexico, SSA, Peru, Salud, we looked at how close they got to that 70 or 80% range given breast or cervical cancer, again, for the eligible population. Finally, Jordana, I just want to make one more comment here. I think a couple of the items are self-explanatory, but when it comes to the numbers that we're looking at, projected stages of disease when presented without screening, this is, and when screened, these numbers, unfortunately, had to come from studies from Western Europe because this data does not exist for any of the countries in Latin America. In other words, and I think that this is a great moment to go back to do a retrospective study now that we're beginning to get treatment of women. You basically have a natural experiment that's taken place. So I think that there are going to be some really cool studies done over the next 12 to 24 months to look at the actual impact of screening programs. But what we had to do is leverage data from a few Western European markets to understand what is the difference between the average stage at which these women are identified when they participate in screening programs and when they don't participate in screening programs and present naturally with the disease. And so you can see that split here without screening and when screened. The significant skew or the more women showing up for both breast and cervical cancer in stage 1 when participating in the screening programs. And so this data was used in generating our models. I will make one last comment, Jordana, I apologize, is that the data for cost of disease was converted to US dollars, looking at constant currency across each market. You can see, of course, there's variance in cost given different standards, the standard of care, as well as costs, the personnel cost in each country, as we know that labor is a large component of any treatment. So if we go to the next page, these are the numbers that we used. Again, this information is available in the report that we've posted on our landing page. I wanted to get a little bit into the big picture impact, right? So what really took place, and this is before going to the outcomes of these models. So what happened during the pandemic in 2020 and 2021? What's pretty cool is we already have some 2022 numbers. I'll just make some comments to those. So on the left-hand side, we have the breast cancer screening programs, again, for Brazil, SUS. This shows up here, Mexico, SSA, and Peru, Salud. We have total women being screened in millions. And then we have your lines are going to be the percent of the target population reached. Again, that percent of target population is represented by your eligible population as defined by the age targeted in the protocols for each country or each payer. Then multiplied or basically controlled by the targeted level that the WHO is suggesting, either 70% for breast, 80% for cervical cancer. On the right-hand side, you have the same graph for cervical cancer. So a few observations here, twofold. First of all, outstandingly, we saw even before the pandemic, Peru's Salud was doing a tremendous job comparatively in reaching its targeted its eligible population for cervical cancer screening. You see that light green line on the right-hand side of your page, reaching 70% of the target. So there's still a gap there, and we'll talk about what that gap means. But you can see it far outpaces any of the other programs, with the exception perhaps of the breast cancer screening in Mexico's SSA in 2018, which had fallen in 2019, even before the pandemic, unfortunately. The second key item I wanted to highlight here is that the rate of coverage clearly dropped in 2020 in all three studied countries to levels about half of the level, more or less, from where you begin in 2019. And when we begin to look at 2021, that first year of recovery, what stands out is Brazil's SUS, or the public sector in Brazil, despite not reaching pre-pandemic levels of coverage, of reaching that target population, did better than both Mexico's SSA as well as Peru's SSalud. And again, these are observations based on the numbers. There's various drivers to this. I think you saw, obviously, all these countries hit very hard by COVID, but each country and each payer system has a unique, let's say, arrangement of how they're treating the COVID patients, and also where these screening programs are being delivered, and how that delivery of the screening programs is actually impacted by the efforts needed to be made to treat the COVID patients. So there's a lot that goes into that recovery, but we did see, again, Brazil's SUS beginning to recover in 2021, and they're back to about 2019 levels as of late 2022. Now, what does this mean? The next question is, A, what is the impact of the pandemic, that drop? What does it mean for what we can expect over the next couple of years, right? Because these patients that weren't screened, that are in theory going to arrive in later stage disease, and I have some data later on, Diego already showed it with Brazil, but I'll bring it back to reemphasize this point, that would suggest that this is exactly the case. You have these patients arriving later stage disease that will have worse prognosis and also generate more cost for the healthcare system. And then B, you also have this question of, we've got a long ways to go to get to that, to max out the targeted population, even discounting for what the WHO says is even probable. So Jordan, if you go to the next page, I just lingered there for a second. I think those numbers are really powerful. So what I want to look at here is some of the results of the study. Again, as more data comes in, I think that there's different ways you can look at this. This is what I would really call it more, we had the historic data of who hadn't been through the screening programs, but we had to make an estimate based on the data I already showed you, of what would be the impact in the human impact and the economic impact. So if I might start, actually, I'm going to start on the right-hand side of the page on the human impact, because I think it's more, much more important, especially when you begin to see the actual cost. The costs are significant, but if you begin to attach that to the number of lives that are being impacted here, I think it's quite apparent that it's quite minimal if we want to solve this issue. So we have a comparison here of the number of women per 100,000, and this is to allow for a comparison between the countries. So the number of women per 100,000 women covered by each of these payer systems, that because of the impact from both having suboptimal coverage before the pandemic and therefore as we exit the pandemic, as well as the impact from the pandemic in 2020 and 2021, will end up presenting in late stage disease. And again, this is based on some of the estimates that we've seen, the studies from Western Europe, as well as the key inputs from the markets that we're looking at here. So the key takeaway here is, again, you have massive human impacts from both of these drivers, but I want to convert these per 100,000, which allows for the comparison. You see in Peru, the impact per 100,000 women was much larger because there was a longer delay in actually getting these women back into screening. In fact, what we saw across the healthcare system, Peru is probably, I would argue, the worst hit country possibly globally when it came to delayed access to healthcare because of COVID. Now, when I put these into absolute terms for breast cancer, I'll highlight here, the breast cancer patients are going to be, for Brazil, the total number of women that would present in late stage disease rather than stage 1 would be 8,480 individuals, and that's on an annual basis. both from the under screening against target, as well as the drop during the pandemic, the 2 pandemic years. For Mexico, that number for the SSA is 5,900 or 5,900. And for Peru's S-Salud, it's 2,000 women. So combined, we're looking at around 18,000, 19,000 individuals here that end up only being able to start treatment in late stage disease. From an economic standpoint, you're seeing 2 different numbers here. The first number is that impact from the women presenting in late stage disease because of the drop during the pandemic. The other one's because we're not even back at targeted levels as 2021, which reflects back to basically where we were even before the pandemic started. So the total impact here, it's pretty clear, both for Mexico's SSA as well as Brazil's SUS. You're looking at around $150 million. And this is on an annual basis, just from not hitting that targeted level, you're looking at around $115 million US a piece. So if we begin to think about simple actions, low cost investments to increase screening, capture, or identify these women in early stage disease, reduce this cost. The investment can pay for itself, but also clearly open up budgetary space for better treatment, possibly curative treatment for these women that are identified in early stage disease. In Peru, in this case, we're looking at total impact of $55 million US, and of course, much larger, much smaller population here. Of course, the total covered population, I'm talking men and women for Brazil SUS. In theory, it covers the entire 220 million. In practice, you have to subtract the privately covered individuals, so you're looking somewhere closer to 170 million. While in Mexico, the SSA is around 60 million total. In Peru's S-Salud, you're looking at a much smaller numbers, only a handful of million of individuals. So that's the reason for the smaller economic impact, despite the deeper drop from the pandemic. So Jordana, if you go to the next page, I want to share some of the same numbers from the, well, I lied. I've forgotten about, I was pulling this forward a little bit because I want to highlight, this is the numbers that Diego had previously demonstrated. And I think that these are really fantastic because these are numbers that we've only had as of recently, and it's sort of demonstrating, going back to the numbers that we don't have for Latin America yet. That would be fantastic for someone to conduct a retrospective study to make these estimates, which are, what's the impact between patients that participate in screening programs and those that don't. But here what we have are the percentage of total breast cancer patients identified in Brazil's public system, or SUS, that are being identified for the first time in stage 3+ and stage 2+, as a percentage of all women being diagnosed with breast cancer. And I think the message here is quite clear. As of the beginning of the pandemic, for stage 3+, we went from only 49% of those women that were being diagnosed with breast cancer were stage 3+, to the latest data point that we have at the very end of the latest, data point. There's not full reporting for many of the months of 2022. So the best confirmable number that we have, December 2021, is 57%, or a full 8% increase. And I made an estimate here of how many women that actually would mean are presenting in stage 3+ against earlier stage disease, just due to this gap, right? And it was about 2,000 women over one period. So again, very large impact, but I think that these numbers really highlight that when Diego came to us and said, hey, we need to look at this, he was spot on. And I think that it's quite clear that we need to continue to give greater attention to these data points and better understand what we can do. So if we move to the next page, Giordano, I want to look at, yes, I'm not mistaken this time, the results from cervical cancer screening. And so quite clearly, the first takeaway here is you have a similar situation where the impact for S-Salud was much greater. And again, it's because you didn't get the rebound in 2021. The economic impact for Brazil in this case being the largest, just because you have the most number of women there. But if I go back to the numbers and just a little bit of highlight, the methodology, the logic is quite the same. But we're talking just in the case of Peru here, because of this extreme drop in the figures. If we take both the lack of being at the target level, as well as the women not screened in 2020 and 2021, we're talking about nearly 15,000 women showing up in later stage disease against the counterfactual. So again, when we look at the cost on the left-hand side, we are only simply looking at the difference in treatment cost. We're not considering the difference in the value derived from the patient, from not having to undertake a much more extreme treatment, in many cases with later stage disease, the impact to the caretakers, as well as broader societal impact of having these individuals as active participants in society and in the economy. So if you go to the next page, then I want to make sure we get over to Camila to speak a little bit about what we can do about this and what Camila and her company are currently doing about this issue, which is clearly, I think there's a lot of low-hanging fruit here, but I want to make two last key points. And that's about some of the socioeconomic drivers and what's driving this. And Diego already sort of brought this to the table, but what we looked at here was the impact on, for all of these countries. In fact, it's really cool. We have data at the state level for Brazil, the state level for Mexico, the regional or provincial level for Peru. And you can begin extrapolate some of the drivers, right, of what is happening by looking across these geographies. And we first wanted to ask, is this a matter of underinvestment? What's happening? And so in the case of Peru here, I think there's a lot happening. And what we learned was it's not, yes, there are socioeconomic drivers. There definitely are socioeconomic drivers where unfortunately less states in all these countries and municipalities with less resources have been historically less able to invest in capacity from a mammography perspective, as well as their programs for cervical cancer screening. But also you have things like here, for those of you familiar with Peru, are going to recognize that you have the key hospitals in Lima, which were more directed towards treating COVID patients. They had a larger impact and were unable to as well attend these screening programs because their attention had to be fully converted to COVID. So that gets back to one of the comments earlier before. How are our systems designed? Are these programs separated into specific primary care facilities? Are they incorporated into hospitals that might be disrupted by another pandemic? What does that patient journey look like? And if you go to the next page, Jordana, my last point here before handing over to Camila, bringing back one of the numbers from Diego, but I really want to blow it up for you guys here. This is from Brazil's private system. So clearly the impact was huge. And again, we would have loved to have performed the same sort of analysis for Brazil, but as you can see here, this is total mammograms. You can't divide this by what's part of the screening program and what's not at this time, at least. Interestingly, there's legislation, a proposal to have that data reported directly from the private payers for Brazil, which would be really cool. But I think the key takeaway here is that much faster rebound. You're actually still slightly below. You're at about 97, 98% of where we think you would have been as of the end of 2021, which is the last data point that we do have. But the key point is clearly there's a discrepancy in access, but it also opens up opportunities. And the one that jumps out here is public-private partnerships to really facilitate that access for the broader population, which can reduce cost, allow for greater investments in other areas. So with that said, I think that the study's been a lot of fun for us and very insightful. I think that we've seen that with data, there's a lot of data that exists that we can do a lot more with, but also there's a lot of data gaps across these countries. So I want to ask a polling question here, and then we'll pass off to Camila. If we can launch the next one. What's the greatest barrier to improve access to cancer screening programs in Latin America? A lack of prioritization from a policy perspective. So this is just not at the top of our list. A lack of investment. Is it maybe it's top of our list, but we're not putting forward the investment, which can have significant return, as we've already seen? Or is it knowledge of the low-hanging fruit? low-hanging opportunities as expressed here to expand capacity and enhance quality. I think that this last point, I'm setting up Camila a little bit to dive deeper. So I'll give another 20 seconds here before we reveal some of the responses. I think as we're waiting, my last observation would again be there's just a huge opportunity beyond, of course, investing in these programs to really double down on the data that we're generating so we can have a greater clarity. We would have really liked to run this program across more countries and more pair verticals. So if we can go ahead and show the responses.
And just before this, I want to remind everyone that they can do questions, send questions using the Q&A. You can send in English, Espanol, Portuguese, any language. So please remind to send your questions using the Q&A. Thank you.
Thank you, Diego. So dispersed across all three, which basically means that we have a broad problem, a broad challenge, and we need lots of help. So with that, Camila, I'm going to pass the word over to you to speak to what your company has been doing to address this challenge.
Thank you very much, Alec. I think that was a great presentation. So Jordana, if you want to go to the next slide. Hello, everyone. My name is Camila Pamfilis, and I'm the actual Chief Data and Patient Experience Officer at Mamotas. Mamotas is a high-quality diagnosis and patient support digital solution defeating breast cancer. Thank you very much for inviting me to this event with such relevant and alarming highlights. As Diego and Alec just shared, Mexico, Brazil, Peru, but also the rest of the region need to take urgent action on the problematic affecting so many women. Next slide, please. Breast cancer is the #1 cancer in the world, according to World Health Organization, killing 700,000 women annually. 70% of these deaths occur in developing countries. And this happens mainly because of two reasons. First, as we just talked about, is the lack of early diagnosis. If women would have access to preventive screening and diagnosis, the survival rates would be over 98%. But then there is a hidden solution. The healthcare system, mainly in emerging economies, looks like this. Next, please. It's highly fragmented. It works in silos, and it doesn't collect or share data on patients. So even if women would get access to early diagnosis, accessing treatment would be a new challenge, and they probably wouldn't make it on time. Next. So I'd like to open still a bit more the scope of the impact COVID-19 has left. Not only an unknown number of patients have failed to have been diagnosed and treated for various cancers, increasing mortality rates and costs of public investment for advanced stage treatments. Education campaigns are the basis for creating awareness, and they require a lot of effort. But in order to make them effective, continuity on annual exams year after year is critical to make it a habit. For 2 consecutive years, hundreds of thousands of women have been forced to stop this habit, taking them back to the starting point where fear plays a protagonic role. The fear, uncertainty, economic expenses, projections all affect women when undergoing an oncological process. That in many cases lead to mental health issues. And last, quality of life of patients during and after treatment. Usually results are measured on remission or reincidence of the patients, leaving no evidence or data on how personalized precision treatments, reduction in time to diagnosis, and emotional support during the process increase the quality of life of patients. Next. At Mamotas, we're absolutely committed to reducing mortality rates of breast cancer while increasing quality of life of patients. And this is not a promise. Mamotas, it's happening already. Next. We developed and implemented a digital platform to offer an integral solution, starting by awareness actions through all channels and networks that guarantee an exponential increase in demand generation. We designed customer screening programs to help women access Mamotas centers. We make use of hospitals' existing mammography units by connecting them to our patient-centric solution. With teleradiology, our specialized physicians remotely perform the interpretation using AI support, increasing efficiency and accuracy. The platform automatically identifies risk patients that will receive a free concierge service by our health navigators to assist them with emotional support throughout the entire patient journey, guaranteeing their access to early and personalized treatment. During the follow-up process, we collect and structure a monumental amount of data like never before in the history of Latin America, while saving lives. The data sets include clinical, socioeconomic, and psychological structured information. Next. To guarantee the traceability of the data, we have designed, developed, and implemented a proprietary software that collects patients and medical reported outcomes. It's a responsive cloud-based platform that provides an end-to-end solution by integrating different technologies that interact with each other in a streamlined workflow. Next. With 10 years of experience in the field, we have generated great impact. So far, we have reached 600,000 women with high-quality diagnosis and patient support. We are the first solution to have 100% data traceability in Latin America. 87% of oncologic patients diagnosed within MammoTest got to treatment on time, while 76% of them couldn't have done it without our health navigation's intervention. For this, we have received many prizes and recognitions by important organizations, United Nations, World Economic Forum, MIT, Science Sustainability Prize, and Norske Foundation being some of them. Next. During COVID-19, MammoTest was operating in Argentina only. The average national drop for breast cancer screening was of 67% during the first year. Overcrowded hospitals had to restructure their services, prioritizing COVID patients to avoid spread of the virus. But breast cancer, as all other cancers, doesn't stop and wait. Here are some actions that helped MammoTest keep the dropping number in 27% and recovering to our 90% capacity after only 6 months. First, telediagnosis. No physicians are required to be in place at our diagnosis centers, keeping doctors safe at their homes. Then, minimal staff. Our technicians are trained to give a full service, reducing significantly the chances of contagion. Obviously, awareness. Without minimizing the COVID's impact, we continued running awareness campaigns through different channels as a reminder that cancer doesn't know about pandemics. Fourth, prioritizing the age and risk patients. The first hours in the morning were blocked for high-risk women, for example. Then we have emotional support. Our health navigators, very much aware of the critical psychological impact of COVID, went an extra mile with their support and reminders throughout the whole journey, guaranteeing that patients wouldn't stop their diagnosis or treatment process. Six was the patient recalls. We personally contacted all patients that had missed their annual screening within 2020 and 2021 with appointment reminders. And last, we delivered digital results to our patients and doctors. Our in-house design platform allows us to safely deliver results within 24 hours in a digital format through a personal portal. Medical quality images and reports are stored permanently in their clinical records, so patients wouldn't have to come back to fetch results. Next, please. Our solution can be connected within 7 days. Our model is assetless, highly scalable, and it's replicable for our diseases. Our platform is 100% data structured and tech agnostic. We have designed a patient experience that keeps fidelization rates over 86%. Next. But in order to get back to care in Latin America and really save the lives of millions of women, there are 4 key factors I personally believe are essential to create a systemic change. First, investment in education for awareness and universal preventive access. Second, quality in diagnosis, investment in equipment and use of technology to reach geographies where specialized doctors are not available. Fourth, working team, create networks and partnerships to make the patient journey more efficient and effective, while giving emotional support to empower patients to take control of their own health. And fourth, very important, collect and make intelligent use of data to promote evidence-based decisions and public policies. Next. We've done a lot so far, but the path from a sick care to a preventive system takes a lot more. We're already operating in Argentina and Mexico, and we have an ambitious plan of expansion to all the Americas, including Colombia, Brazil, and underserved US in the midterm. We're looking for partners to join us in this challenge of giving all women the opportunity to live healthy. Pharma, NGOs, AI companies, diagnosis centers, government and health insurance companies willing to take breast cancer fight to the next level are welcome to join us and scale Mamota's solution to every corner of the world. Next, please. This is how we are already building the path from a sick care model to a real healthcare system. Will you join us? Thank you very much. I'll now leave you with a third polling question, and please help us answering it. So what data evidence indicators are the most relevant for decision making? Here we have 4 options. None of them is the correct. The first one is socioeconomic. The second one is treatment effectiveness. Third, time to treatment. And fourth, geographic distribution. We'll give you 30 seconds to answer it. And this will give us really good insights for the Q&A probably.
Yeah, Camila, I'd like to have all of these. I look at them and think about the project that we ran, and you had geographic distribution, but you didn't have the rest, and you really couldn't connect it all together with the data the way it was. So very interesting.
Mm-hmm. Jordan, we already have the answers.
We can show the results now.
Sure, thank you. Interesting.
Yeah, Camila, I think you hit on the key. It's how do you connect all of that together, right? How do you? Yeah, it needs to all be linked, and that's the challenge. And that's a little bit what you were talking about your experience.
Exactly. I think here creating partnerships is essential. Sharing data, collecting data. None of us would probably have the such specific data, but if we are able to put all this together, I think we'll have very, very interesting highlights and insights on how to really take breast and cervical cancer to the next level.
100% agreed. Jordana, do we want to move to the Q&A?
Yes, thank you for the polling. So thank you to all the presenters. We will now walk you through some of the Q&As that has come through the audience. So I'll ask the question, and you guys can let me know who would like to take it. So what are the keys to driving improved quality of screening programs?
Yeah, I don't know, Diego, would you like to comment on that one? What you think is in terms of the quality or ability to decrease false positive or false negative and false positive tests? What have you seen in terms of the opportunities for investment?
So I think, and this again with my hat of a public health doctor, not the company. So I think when you look at screening, you need a radiologist that is going to be trained to read the screening. So in our radiology programs in general, Latin America, when people is doing a rotation in the National Cancer Institute or in a hospital that mammographies, they might spend maybe 1 month there, a couple of weeks. And of the screenings, mammographies that they're going to see, many of those are normal. You are basically looking at population that is healthy, that is going to do the checkup. And yes, you might find some BRADs 3, 4 maybe where you have to have a biopsy, but most of those are normal. So there is receiver operated training, right, to be able to detect. So a computer-aided diagnosis, something like a mammo test, what the solution is, artificial intelligence can help to improve the precision, right, and to also offset the cost of having a really well-trained radiologist and offer the same quality of service across all the region in the country, right? That is one point where we can work. And when you look at cervical cancer screening, most of our countries are doing pap smears. And there is, I think it's a very efficient way to do screening, but this again relies a lot on the technique of the people that is doing the exam, how they prepare the sample, and then who is reading. And again, artificial intelligence might be an option to look at if you have tiny microscopes or if you have little microscopes. That might be an option. But a better option would be to do a PCR test, take the virus. So I think those are kind of the initial reactions. But maybe Camila can comment more on this, how you can improve quality. Our quality, when you look at the I will just stop here. The accuracy that you reported, Alec, for the Brazil, Mexico, and Peru cases is very poor, right? I mean, it's not only that we were not doing all the tests that we should. We're not bringing all the people because capacity or efficiency in the way that we book, we appoint, we made appointments in the system, or the hours that we operate in the public sector. Maybe it's not at the full capacity, but also was the quality, of the equipment or the training of the technician or who is reading that was not working well, right? So it's not only about the quantity, that is maybe what the countries are focusing now when they are trying to expand capacity, but it's also about the quality, right? So maybe you can do the same number of tests, but with better quality.
Excellent. Camila, do you have anything? Do you want to add anything there?
Yeah, I think that's it's important to understand that quality as a final result is clearly a combination of many factors. Investment in technology being the first one. In Argentina, for example, 70% of mammogram units are still analogic, so that reduces quality significantly. The training of technicians on how to take the medical images of the patient, how to support patients throughout the whole experience so that they can feel confident they don't move and we have clear images. The fact of having specialized radiologists doing the interpretation, and this is a main issue in the geographies where we work, where specialized radiologists are not there. They usually concentrate in big cities where they have better job opportunities. So here using technology again and telediagnosis is a really important factor. And yeah, I think it's somehow a combination of all these factors that are really important to really, as Diego said, not only increase the number of screened patients, but the quality of these screening programs.
Yes, sorry, Alec, if you allow me, and Jordana. So as I mentioned to you at the beginning, this is very close to my heart. So when I was doing my epidemiology postgraduate training, I was looking at this mammography. How can we reach Morena from Colombia? How can we reach isolated areas, right? Amazonia, La Guajira, where you don't have the training, or you are not going to have the radiology. So how can we do telemammography with a Pullman approach, right? Looking at using a scanner, sending this to the National Cancer Institute. But then also it's not only about this, but it's about the experience of this woman with the system, right? So we did also study, and we won a prize in Colombia with a foundation, looking at a CAPA study, a knowledge, attitude, and practice in mammography. And we were asking women, high-income women with a prepaid medicine, that were eligible to have a mammography, where they were not going to take the test. What were the reasons? And many of them were afraid, or radiation, just about, I mean, awareness is just one part of education, or they were just telling us that was uncomfortable. You know, was to call the room, the machine. They didn't want to have technician, you know, close to them, you know, going to the test. Things like that are also impacting, right? So it's not only having everything ready, but also what is that experience with the patient. And then once they have a diagnosis, what is going to happen next? Who is going to navigate with them to the system until they are treated? Or you know, whatever is the decision, the technical, the medical decision on the next step with them. And I think maybe again, Camila, what you are doing with the chaperonas, right? I mean, going with the patient, that might be also something that can add value to our system, right? Because as you were mentioning, there is very atomized, fragmented systems. I mean, we left people just, you know, trying to find a way to get a treatment that they need, you know, once they are, because the screening is not a diagnosis, right? So they need to get diagnosed and get it, and we miss also patients there.
Thank you all. We still have more questions to go through, but I'll go to our last polling question here for all of you, our polling question number 4. So what is the largest data-related challenge with respect to existing cancer screening programs in Latin America? So select 1, data generation. We're not generating and capturing the right data to inform decision-making. Data organization, we're not generating the right data, but it's not being used adequately organized to facilitate decision-making. And last option, data interpretation, we are not adequately leveraging the data that we already must make decisions.
I think that last one should we already have
made decisions, yeah.
Yeah.
Thank you. We'll allow 30 seconds. In the meantime, if you have answered, there's still time to ask more questions. So please feel free to keep them coming through our Q&A feature. And more seconds.
Jordan, maybe we can go with the next question while we wait on the responses here.
Yeah, sure. So the next question here is, what research questions need to be explored next with respect to screening programs in LATAM to inform public policy? Any takers who would like to start?
I'll defer if Camila or Diego want to begin. Well, I guess it's what's the next big research question that needs to be answered by someone that's going to spend time on with this data? I mean, it gets back to the data question. Diego, do you want me to take it, or would you prefer?
No, go ahead, Alec. Go ahead.
Okay. I mean, my first thought is effectively what is the missing data? Like what do we need to generate? Because each country needs a data strategy of what you're generating and what you're following, right? So Camila, and then who do you partner with to generate that data? And then I think second for me, and I already mentioned it, would be we have a very unfortunate but really real, effectively a pre-made study for us to be conducted with the pandemic, this rupture in the access to the screening programs. And it's an opportunity for someone to answer the question of exactly what is the impact of screening programs on diagnosis and early disease within the region. With the disruption that you have a ready-made study. So I think that needs to be unfortunate, but needs to be taken advantage of to answer these questions. Because Camila, Diego, you've mentioned some low-hanging fruit, right? And what we can do. I think, Diego, one of your points is make it more comfortable, but also shift screening for cervical cancer to PCR testing, which requires a little bit of an upfront investment. And to convince states, municipalities, governments to do that, we need to be able to show the real outcomes, which we know that has an impact, but let's go ahead and take this opportunity to demonstrate just how impactful it really is. That would be my answer.
Yeah,
I don't know if anyone wants to add.
Yeah, like I think, you know, because it's like a piece. I mean, when you look at the news that we shared at the beginning, I mean, companies are doing effort, right? So they are, I mean, the different systems, they are buying more machines, equipment, they are training people, they are doing things to try to get people back to the screening. In the October month in Brazil, they reported that 40% increase in mammographies in October, right, because of the breast cancer month. But how can you know make this more systematic, not like a one-off campaign? How can you do that? And I think there is some underappreciation of screening, right? So I mean, because I mean, you show us that we're not doing great in these three countries, right? So we were not doing great, and now we are just barely coming back to the level we had pre-pandemic. So I would say that, you know, in terms of policy, I mean, there are different policies, and maybe we don't, and some countries have policies like Peru, right? So they have a cancer law, they are doing some changes in the way that they operate, but still, you know, it's not about the policy, but more on the execution and maybe looking at the short term, what can we do? Identifying the patient, right? Increasing the awareness, improving the quality, and then what can we do long term, and maybe or midterm, and maybe that moving from analogy mammography to digital is one in the screening, breast cancer screening, and then moving to PCR or, you know, trying to do different with cervical is another one. One thing that we also see, and I think you didn't mention this, Alec, is the target population. A policy, I mean, we are looking at the data, and most of the women are coming out in a younger age. I mean, most of the women that are diagnosed with cervical cancer or with breast cancer. So if you are only screening in Brazil, women older than 50 or 50 to 70, you're really missing, right? At least a decade of people that should be screened according to the right? So what happens? You screen them. Right. Yep. I mean, assuming that you have the capacity, because we have seen that they are not at capacity, right? They were not at the beginning. It's not about the number of equipment. It's just about the efficiency of the system.
Yeah, Diego, you make a good point, because in fact, we estimated the impact based on what each country defined as their eligible population. And within the eligible population, you had a target population, which is a discount of the eligible population by what the WHO is tells you should reach as a standard. So to your point, we even potentially underestimated the impact from lack of screening, because we made that estimate based on the defined eligible population, which, as you said, it could be, the argument could be made that the eligible population actually needs to be expanded, which would have pushed all of our numbers actually up. So I think that's a great point. So I'm going to just read the responses here. I think for me, the response is quite clear. You have really hardly any votes with data interpretation, because we're still not in the level of generating the right data to make these great insights. Another insight that jumps off the table for me that we can't make is, for instance, these individuals that are identified in early stage, how long does it take them to get to treatment? Because we can't follow the entire patient journey, right? We have in some countries average delay to treatment start following diagnoses, but then you can't break that down by what percentage, break that down between for those patients identified within screening programs in early stage and those identified because they presented naturally. And again, if you want to get the true effectiveness of these screening programs, you would need to then know how long does it take to get to treatment, or is it simply they're identified early, but then they don't get to treatment in time, and so they progress in their disease anyway, which would be even a larger catastrophe. So Jordan, I think we had one more question, perhaps. You're on mute.
Thank you. So the next question here is, what is the most important data analytics that payers can focus on to improve outcomes through their screening programs?
I think it's a great, maybe, Camila, it's a hard question, but maybe from your experience so far, and you mentioned some really interesting things from Argentina, but from the data that you guys are creating and generating, if you're making a suggestion to payers, whether it's public or private, what do you think is the most important data point for decision making? You're on mute. Yeah.
Thank you, Alec. Yeah, I think that I don't think I had the final or right question answer, but as a conclusion, also from was polling question number 3, I think the combination of data is really relevant. Socioeconomics are usually not included, or the time to treatment, and I think there we had an interesting highlight on what's the deal when having high numbers of screening women on a program, but then time to treatment anyway goes too long and the stage of the cancer advances. So I think that considering psychological information, socioeconomics, and clinical regarding and process regarding time to treatment is, for me, the most relevant. Psychological data is never included on these things, and as we've seen as a result of our patient navigation programs, almost 90% of oncologic patients have somehow things blocking them psychologically to move on, rather telling them to their family, taking care of economic decisions on their treatments. Most of the things affect psychologically patients that would probably drop off the treatment if they are not, if they don't have an emotional support during the process. So I think that it's somehow a combination of all this data, from a medical point of view, from a psychological point of view, and from a procedural point of view, the time to diagnosis.
Okay, no, that makes a ton of sense to me, and I see these large payer groups. You've had a lot of investment coming from private payers and private networks across Latin America, and I think there's going to be a lot of interest in those solutions specifically. One that you mentioned is that if you can generate that data from looking at the entire patient journey from once they go through the screening program to actually getting treatment, I think that would be absolutely phenomenal, and I would personally love to see it implemented within a large public system. Jordana, I have another question here. Do you mind if I read it this time? All right. So some things require investment and other things are what we'd call low-hanging fruit. Dig, you already mentioned some of them, some of the low-hanging fruit, but what would you say are the top couple of easy wins? In other words, without making large investments, what can we just do right off the bat that you see as quick wins that could be implemented in the next 12 months?
Yeah, so I think, capacity, we have capacity that is not being used to the maximum, right? So even without going to expand capacity, contacting with the private sector is something that is being done in some countries like Mexico, right? So they are trying to expand capacity, contracting with the public, with private sector separating. Just with your current infrastructure, you can just do better booking of appointments, right? And you can maybe, that is something easy that they can do, the system can do. Second, you can tap into artificial intelligence. You can tap into companies or partners like, private partners like can be Mammoth, so or any other private company with interest in this area, right? Just to improve the accuracy of and precision of the diagnosis. Just by doing these two, there's going to be an impact. And what I would like to see, or what we are thinking now, what we can do to help this call to action and show people this is something that is going to have a return on investment in the short term, is what investments should you do, or what, how can you maximize what you have, right? Is improving with the booking of the appointments, is improving the quality, is doing a mix between the two, and then how much is the investment for that, and what are the savings that you are going to realize? Because as you were presenting, Alec, the cost, I mean, is significant. And we saw in the Dominican Republic, it's a small country, it's a half of an island, and they start to see many patients coming like never before, and they are coming with late stage disease. So if you come with late stage disease, you have to pay for therapies, right? It's not like if you come with a early stage or, in breast cancer, and then you have a biopsy and maybe the patient is cured, or you come with a cervical, you diagnose early, you do a colposcopy, and that woman is going to be cured. That is not the case, right? So they will require systemic therapies. In some cases, they will require some, therapies that might be biologic. What is the cost of doing that versus improving your capacity, right? So the evidence is that we just need to be able to put this together so then policymakers can make an action. Patients, society can also ask for this, and then the medical and other stakeholders in the sector can articulate their response, right? So I think a lot of work to be done with the coalitions, and we cannot continue having only the numbers. But I mean, these are numbers. I mean, the numbers that you are presenting are, but each number of those is a woman, right? That should not be suffering this or should not die because we have a system that is maybe not delivering on what is coming. So they cannot, only a number.
No, it was really interesting, right? Because we started with how is this impacting the system, and we created a model, and the first input to that model is an individual that is identified in late stage disease, which is a terrifying experience for anyone, and that those numbers were much larger than we thought they were going to be. And I think we got deep into the study, and we realized that was by far and away the sort of the big messages that they were mounting up into the thousands. It wasn't just a couple of hundred individuals, which was not what I expected. So Camila, I think we have one last question for you. I want to make sure we leave time for any closing comments, I think from Diego, but the question is going to be around what's the biggest challenge for finding partners to implement your solution across the country? So what are you looking for in a partner?
Well, as I've said before, we create partnerships for many areas, NGOs to use demand generation on patients that really need it, AI companies willing to implement their solutions in a field, in practice, which many times is a challenge for them too. Health insurance companies willing to save money at the end of the day, by making the treatment process more efficient and effective, and especially diagnosis centers, centers that already have maybe invested in a mammogram unit. They don't have they have spare time on their equipment. They're willing to get a solution that somehow is key on the end-to-end process, while creating data. We're connecting on all these partners who we are generating and using data for decision making, and obviously governments. I think here is a big conclusion. We need private-public articulation to really make a difference in these results. So we are really open to all kinds of partners. I think this is something that has to be done in teamwork. Everyone has the ability and added value to give to this whole end-to-end journey. So please contact us. We are looking for partners everywhere and of all type to really make a difference in the world.
Yeah, and I think you just said something I didn't realize. So you're suggesting that where there's installed capacity, but there might be suboptimal utilization of that capacity, you guys can actually just step in right there as a partner.
Yeah,
okay.
It's 7 days, it's enough to connect the solution to any center, and it's done.
7 days, yeah. I can see a lot of both provider groups serving public payers as well as provider groups serving private payers that should be interested in that partnership to position themselves as a better solution for that payer ultimately, connecting back to the point that Diego was just mentioning. Jordan, I've noticed you started sharing the screen again, so I'll stop there.
Yes, so thank you guys. Thank you everyone for sending your questions. Hopefully we covered most of them. So if you have any additional questions after today's session, please feel free to share them. I would like to pass on the word to Diego to walk us through our closing remarks.
No, thank you, Jonan, and thank you, all for staying until now. I'm going to be very brief. Again, going back to my slide on the key messages. I think public-private partnerships are required. I ask you to go and check the Women's Cancer Initiative in the Americas. There are some interesting things there. But first, we need to increase awareness for breast and cervical cancer, and in general, cancer, any cancer that is subject to screening, to a national screening program. Can you do the next click? The second is we need to improve the screening and early detection services, and remember this image in your head, right? So if we can detect something early, that should be the best way to do it, and we can save lives. And next, and the last message is we need to get better data, right? So we need to have the ability to make decisions, inform on the data, and not be like blinded, right? And just take with a guesstimate on what we should do. So I think Latin America has an opportunity. We see other regions that are doing better, and I think we can leverage what they have done and do not reinvent the wheel with the registries. So with this, I will pass to you, Jordana, for final closing, and thank you all again for joining. Thank you, Camila and Alec, for very nice discussion and presentation.
So thank you everyone for your time. Thank you for your presentation to the presenters. The closing remarks here, just high level. We wanted to allow access to this information, so the recording will become available to all of you guys that registered. An email will be sent out to you with the recording. This will also become available on our landing page. And then we also encourage you to access this information visiting our landing page. We're going to drop off on the link here on the chat, and the information is there. You have access to the report where you can fill out a form to receive a more detailed version of the report that also consists at country level analysis in local currency, which is also illustrated in the infographic on our landing page. So with that, I would like to thank everyone for your time and hope you guys have all a great afternoon. Thank you for your time.
Thank you very much to all of you.